training for clinicians. We're very glad that you're with us. In a second, I will turn it over to Sherry from XPIO Health to do a couple of things. You're all muted, so if you want to ask a question, and I think Sherry's going to be pausing on a regular basis for questions. Yes. Yes. So type your questions into the question box or click the hand icon next to your name to let us know that you want to say something, and we'll unmute you. This webinar is being recorded, so we will have it posted in a couple of weeks probably on our website. And Sherry will be giving you instructions about how to do the exam at the end. So I'll hand it over to Sherry.
Okay, thanks, Joe. Hi, this is Sherry Silvera. I'm with XPIO Health. Thank you all for being here today. We have one person in the room, so Kim made it all the way from Yolo County. Welcome, Kim. Everybody else on the line, thank you for taking the time this afternoon. I've been, through my career, been a clinician, an IT manager, worked at a software company, and now work for XPIO, and we're doing HIPAA security and privacy assessments for several of our customers. And training is a really important piece in that, the whole compliance effort. So today we're going to talk about HIPAA compliance with a clinician focus. If any of you were in the HIPAA executive training several months ago, you may hear the same information, because we're going to be talking about HIPAA from the beginning, but then we're going to add some things in here tailored for a clinician. So with that, there are two handouts in the webinar. There's the agenda for today, which documents everything we're going to be talking about today, links to the resources that I'm going to mention in the class, and then there's also the instructions on how to sign in and take your exam. We had some confusion last time, so we wanted to make it a lot clearer this time. All right, so let's get started. Oops, I have to use this to advance it. Okay, hang on, people. There we go. Takes two to tango. Okay. Everyone, HIPAA stands for Health Insurance Portability and Accountability Act. It was actually enacted in 1996, so it goes back quite a ways. It was under Title II, and it actually covers quite a few different topics in the regulation. Administrative simplification, rules about preventing healthcare fraud and abuse, medical liability. For those of you that might have some experience with billing, this is where we got our standard formats for file transfers. So the 837, 835 file formats was part of HIPAA. And actually then security, which covers administrative, physical, and technical safeguards, and privacy. So the class today is going to focus on the security and privacy sections of the rule. Now, move forward a little bit in time. 2003, there was a new regulation, Health Information Technology for Economic and Clinical Health Act, which is a real big mouthful, also called HITECH. And then 2009, they expanded on that as part of the American Recovery and Reinvestment Act. So as you can see, they keep, improving and making modifications to the regulation to try to fit the new requirements, new processes that are coming up in healthcare. Now, is looking at things like meaningful use. Some of you may have heard about that. Those are incentives that are part of the regulation to help folks get on an electronic health record. So there's ways that you can apply and receive money to get yourself electronically set up in your health record. And they also added teeth to the HIPAA rule. And what I mean by that is there's now regulations that are very penalties that are part of that, breaches. So they're really trying, the government's giving us the message that they really want us to take HIPAA seriously. They have this thing out there called the wall of shame, and I added the link there. What happens is if you, as an agency, have a breach that affects more than 500 patient records, and we'll probably call them patients or clients today, you have to submit that report to the Secretary of HHS, and your data goes on this wall of shame. So, check it out, see what's out there. You can see what kind of breaches are occurring and the penalties associated with that. Some of the additional changes they made in 2009, actually now we're moving up to 2013. There was another rule passed, Husband Rule. We talked about the Notice of Privacy Practices, or NPP. You're probably familiar with this. You probably give these to your clients now when they're admitted to your agency for care. They have to be given to everyone, and it explains things like their rights as a client receiving services from you, how they can report a breach, or if they're concerned about some of their data, who they can talk to about it. There's quite a lot of information in the Notice of Privacy Practice. They also talked about business associates, and we're going to talk about those in a little bit more detail later. But essentially, those are folks that you might contract with to help you as part of your treatment services. They're not doing treatment, but they're doing other things, like, for example, billing support or dictation services, things like that. People that are exposed to your client's information, but they're not providing actual services. The government says you are now just as responsible as the person providing healthcare services. They saw that a lot of business associates were not following the regulations and had a lot of breaches. So they changed that up a little bit. They do talk about policies and procedures now pretty clearly. They identify which policies and procedures an agency has to have on board and be following as part of your HIPAA compliance program. Training, they mentioned training. It's great you're here today. The training requirements are pretty specific. It's up to each agency to determine how they're going to do that training, but the government makes it really clear. They want everyone working in healthcare or as part of that business associate arrangement to be trained on HIPAA. And audits. So some of you may have heard about that. They're putting more and more money now into coming out to audit smaller healthcare agencies as well as the larger hospitals to make sure that your program is up to date and that your staff are aware of what to do in the case of a possible incident. A lot's going on. Some other mandates, they're talking about breach notifications. We're required now to notify if we suspect a breach. They did expand those client or patient privacy rules. It did a lot of work on security, and this isn't really the technical class, but security has a big component of technical software protections, hardware, infrastructure, that kind of thing. They're really trying to make a point that clinical staff can do their job with the clients, can enter into a software system, but a big part of protection is the security side. There are those penalties I mentioned. They actually increase the amount of penalties that can be dished out to folks, and we're going to talk about that in a little bit. Office of Civil Rights is the enforcement authority, and also the state's attorney general's offices come into play as well. So lots of effort around us making sure we're protecting our clients' information, not just the paper, but as we move into the electronic world, electronic PHI. So I mentioned business associate a little earlier. These are two definitions that are important that you kind of understand. A covered entity is a healthcare delivery system or a provider, someone that's actually providing care. It can be a doctor, a clinic, a dentist, a nursing home, pharmacies that transmit data electronically, and then healthcare clearinghouses. Those are agencies set up that kind of take your data. They might reformat it. They might change it up a little bit to submit it to, say, a payer or eligibility, that kind of thing. Business associate is a person or an organization that functions on behalf of the covered entity. Like what we were talking about a little earlier, they're not actually delivering services, but they're working with you or the folks that do deliver service, and they're exposed to your client's data. I mentioned a billing support person, coding vendors, transcriptionists, people that you contract with, your software vendor that has access to your clinical information. Might be a good time for questions. Do we have any questions on what we've covered so far?
The only question is, will we have access to the PowerPoint?
Yeah, we can post the PowerPoint. Mm-hmm. Okay. And you had said probably in a couple weeks it'll be out on the website. Is that right?
Yeah. We'll try as quickly as possible. Sometimes we have technical difficulties. I don't want to overpromise.
Okay, good. If it gets out there early, then it's really great, right? Okay, so part of the HIPAA regulation identifies certain roles that your agency needs to have assigned. A security role is defined responsibilities that a person or a group of people take on and manage at your agency to make sure that you are HIPAA compliant. This is a list of some of the ones that we work on our side. Security compliance officer and privacy officer are two that are actually stated in the HIPAA regulations. The additional ones here are roles that we identified as being just as important because you want your HIPAA compliant program to cross all departments within your agency, not just IT, not just your privacy department or your quality management department. Everyone needs to be involved in the program. So security compliance officer, this is somebody that's responsible for developing and implementing the security policies and procedures. They're actually responsible for working with the technical infrastructure at your agency. They are responsible for access control, meaning you get a new person hired at your agency, they're a new clinician, let's say. The hiring person or HR may tell IT what permissions to give that person. You know, what are they allowed to see or do in the system, that kind of thing. Privacy officer is responsible for ensuring the organization's privacy rules and other responsibilities around that privacy regulation are met. Typically, they'll be the person that will receive your incident response form. Let's say you have a form at your agency that you complete if you're concerned that somebody's information may have been violated or breached, their privacy violated. Your privacy officer will take that, they'll do the investigation and determine if a breach has actually occurred and report that to the proper agencies or level of authority. I don't know if we need to go into each one specifically. IT security manager, that's pretty well defined. Workforce security manager, that's usually someone in your HR department. It's someone that's making sure all the staff are trained, and if someone does break the rules, that there's some kind of sanctions or violation process that occurs. And you'll see later on around the penalties, you know, we're all human, we all make mistakes, things happen. But if someone repeatedly makes the same type of mistake over and over again, the government really wants us to take some kind of action. So think about it. If these are new terms to you, think about who might be your privacy and your security compliance officer. Hopefully they're not new terms. Hopefully you know who those folks are. If you don't, that's write down a piece of homework assignment for you. I want you to go back and find out. So these are two people. It could be the same person too. Government doesn't say you have to have 6 different people, but you do have to have people that are responsible for making sure your program is compliant. Any questions about that? Alrighty. Reminder from Microsoft. We all love those, right? So we've been talking a little bit about our clients' information, protected data, that kind of thing. Technical term is protected health information, or PHI. You might have heard that before. What that means is, in terms of paper as well as your electronic system, what data about your client is considered protected and needs to be secure, so your client's identity or any kind of privacy around what services they're providing, that kind of thing, might be exposed. This is the list of the data elements that make up protected health information. So you can see pretty much it's most of the information we collect when we admit a client to our system. You might not collect their driver's license number or their vehicle license number. You might, if maybe you're working with the client on some kind of a driving violation or something like that. It's important to think about pictures, photographic images. Those are also considered PHI. If you might happen to take their fingerprints along the way, that's considered PHI. Any other number you might collect on them. Let's say your state requires you to collect some sort of data for your state reporting. If it's unique to that person, it has to be considered protected. Last bullet's kind of interesting, and what that's on there for, anybody over the age of 89. So it kind of looks weird just sitting there by itself. But the idea is the government wants us to think kind of the bigger picture. So let's say you live in a small county and you have a newspaper article come out about this great services you provide, and that's awesome. We all want to talk about the great things we do. And we say we have an 89-year-old client who's been coming here for years, and he says he's very happy with his care and his life is better. Let's say there's only one 89-year-old male in your county. That could be a possible exposure. He might call you up and say, all my neighbors are telling me they read about me in the paper. And that would be an exposure of his privacy or his PHI. So it's good to think any of these by themselves or together is considered PHI. Yeah, Kim.
Is medical record number PHI?
It is. Yeah.
How about their initials?
Initial? No, probably not. So is that how you currently identify people, like if you're emailing, initials and medical record number? Yeah. You know, technically their medical record number is considered PHI. The risk of someone finding that and knowing who that person is probably pretty low, because they'd have to have access to the system and be able to look that up, kind of a thing. But it is on the list.
Initials or?
Initials, no. It's the name. Good question. Okay, so we talked about those data elements that are considered PHI, but let's talk a little bit about what is protected. There is another term. individually identifiable health information, IIHI. You might hear that. That's more of like the demographic data we looked at. So if someone found somebody's name, medical record number, address, it's considered IIHI as well as PHI. So I think the whole point here is they just want to make the point that even though you're not talking about health information or services that they might be receiving, it's still protected. So we want to look at all medical records and other information used or disclosed by you as a healthcare provider, or remember what you are, you're a covered entity, in any form. And we're talking electronically, on paper, and even your oral communication. And that means what's included in that is data or information forms that are created by you, provided by the client to you, created by someone else and forwarded to you, say in the event of a referral, or data that you forward to others for payment, treatment, healthcare operations. All of that, in the context of those 19 items we just looked at, are considered PHI and PHI that we need to protect. Does that make sense? I have one person nod or no. Okay, so all of us here today, I'm assuming are covered entities, meaning that we work at agencies that provide care and services to clients. So think of yourself as a covered entity. You are permitted, but not required, to disclose PHI without an authorization for a couple reasons. So the government's saying, we know that you have to do your job. It's important that we take care of our clients. We don't want to bind you up into too many, ropes that it's going to make it hard for you. So when you're talking with your client, you can share with them. That's kind of redundant, but you can. You can talk to the client about their own data. You can share information about treatment, payment, and healthcare operations without an authorization from the client. So that means when you're treating the client and providing care to them, when you are talking to other folks in your agency, maybe collaborating on the care plan, you're going to be referring them out for specialty care. You want to talk to that person or send that person information. That's all considered treatment. Payment is about us keeping the doors open, right? We're giving these great services. We have to receive payment for those, so that's billing, sending that data off to a payer or a healthcare managed care group, that kind of thing. And healthcare operations, that's around what you do within your organization to keep the business running. That could include your QM audits, talking as a team about client care, that kind of thing. Now, the client does have an opportunity to agree. That means if they want to maybe bring somebody in the room during their session, they have the right to do that, or object to certain things. One of the things is, let's say, I don't know if your agency has something like this, but you have a roster of everyone that might come in, for a group, let's say. They have the right to say, I don't want my name up on the roster. Keep that private, please. And they do have a right to let you know if they don't want their data used for research, that kind of thing. Some of that's minimal. Public health, we do have permission to expose or share data with public health in the event of some kind of a contagious disease, that kind of thing. Okay. Now, our clients have the right, expanded rights under the new HIPAA laws. And this is a listing here of some of those new rights that came about. They have the right to see their medical record and also get a copy of it if they want to. And that could be paper or electronic, whatever they're requesting of you. They can also ask for amendments to their medical records. So let's say you give them a copy and they come back to you and say, this isn't right. It could be anything from, this isn't my address, there's a typo here, to, I didn't say that in our session last week. I'm mad that you've written this down in my chart. Whatever that is, they have a right to request the amendment. You also have a right to deny certain things, and that's a whole process that is itemized or described in the regulation. Your client can request restrictions if to share their data if, let's say, they're paying for their services out of their own pocket. They can ask you not to share their data with anyone else. They have the right to authorize disclosures, and there's rules about that. So not including the treatment, payment, and healthcare operations type of disclosures. If you want to disclose their data to someone else, you're required to get their signature, their permission to share. They have the right to receive a notice of privacy practices, to get a notification of any breach that might have occurred with their data. They can ask you, tell me everybody you've disclosed my information to that isn't part of TPO. Does everybody remember what that stands for? Treatment, payment, healthcare operations. They also have the right to ask you for secure communications and confidential communications, and your system should have the ability to flag that. That means if I come in and I say, I don't want you calling my home number because I don't want anyone at the house to know I'm seeing you, you have to be able to abide by that request.
That's a question.
Oh, good.
Just to clarify, if a client brings a family member and wants them to just attend one appointment, is a signed release needed?
They have the right to have someone in the room with them. So I would say you probably don't need a signed release. If your agency has people sign the release just for one time, that's okay. Never hurt, you know, to ask for that. But per the regulation, they can actually ask somebody to be in with them, and that's their right. Is that it?
Yeah.
Okay, good. Good. So, you know, HIPAA sits at the federal level, and that means that the federal government is writing these regulations for all of us that we have to comply with. And then each state has the ability to write their own regulations. A lot of the state laws happened even pre-HIPAA because states had to worry about that before 1996. So you kind of have a combination of federal and state. You might even have local county regulations that your county has imposed. The point being, we have to follow all these different regulations. The rule is you have to follow the one that is the strictest. The most strict rule trumps everything else. Doesn't mean you don't have to follow the other one, but in terms of HIPAA, if you have a state rule that's a little bit more strict, you have to look at that. I just listed some of the California laws here or rules about privacy and security. Some of you may have heard of CMIA, Confidentiality of Medical Information Act. There's information practices, a couple other ones here I've noted. In behavioral health, we also have Title IX. We have LPS rules that we follow. You know, the point being that I'm sure you're feeling like you're having rules and regulations coming at you from all sides. But the strictest one is the one that's going to prevail. I just have, this Windows thing is going to get in the way today. There's a reference for you to get to this complete document. I found a document from the California Hospital Association, and what they did is they started looking at HIPAA and the California CMIA law, information rule. and they were just analyzing the rule. Now, I can't say that they did the whole HIPAA regulation, but it's actually pretty good. And I just kind of took one slide, one piece of the table out here for you. So what they did in the left column is they're looking at the HIPAA rule. So in this case, HIPAA permits covered entities to use or disclose PHI to the extent such use or disclosure is required by law and complies with the law, and that covered entities must comply with specific disclosures without a release or authorization. Now, in the middle, they're looking at the CMIA law, that specific state law, and that permits disclosure of medical information where such disclosure is compelled by a competent legal authority or process. And they're referencing the civil code here. So they're looking at both, and their analysis is in the far right column. They're saying that HIPAA permits California providers to continue to comply with most required disclosures under CMIA. So in that one example, HIPAA looks to be the one that's the most strict that you can follow, and you're still going to meet your CMIA requirements. So check out the reference. It is noted at the bottom of your agenda, and see what you think. You probably have a privacy officer or someone at your agency that's doing this as well, because you're going to have to make sure that you're following the regulations that apply, with the most strict rules. Let's see here. Now, we've already talked about the most stringent law takes precedence. I have that whole chart out there. I think this is just following up on what I was just saying. Yes, Kim.
Can you give like a real world example of how the other graph that you had, how that would look like?
So, for example, real world here, how it would apply here. So this is about how you're permitted to disclose information without an authorization. The rule states that you can release information, let's say in the event if you're worried about child abuse or elder abuse. You don't need your client's permission or authorization to talk to somebody about that. So what they did is they took that and they're looking at CMIA and comparing it to the California Civil Code. And I don't know exactly, this is all I know about what that says. But they have some kind of regular rule or language in there about what you can disclose without an authorization. Does that help?
Yeah. And it's kind of like when you're talking with a hospital, and somebody's calling in for a HIPAA. Does that give information on what you can and cannot?
That would be considered your treatment, right? You're referring the client to the hospital. Mm-hmm. You're okay. Okay, so that's our HIPAA overview, everybody. We haven't really even been delving into the rules yet, if you can imagine that. So here we go. We're going to dive in. So remember I talked about the security and the privacy rules. That's where we're going to really focus today. The Department of Health and Human Services talks about security rules that focuses on the electronic PHI or ePHI. You might hear that term. HIPAA privacy rule sets that national standard for protection of our clients' health information and how we can use and disclose that. And the standards for privacy, that's really kind of that privacy focus. So the difference between the two, security you might think of as your electronic PHI or how all that's dealt with. Privacy is around your client's ability to have their data be protected and what they can request of you around that. So in May 2005, the security rule was implemented, and that was because they were really trying to get all of us on electronic health records. And to have an electronic record, you have to have servers and networks and infrastructure set up to permit everyone to access that record. Some of what the security rule covers is access control. I talked about that a little earlier. Who can access that protected health information? Protecting your equipment against viruses or some Trojans, malware, the bad things that come in. The rule even talks about our passwords, and some of you might really hate your IT people because they might mandate you to have a strong password. That's actually part of standards associated with security. How folks access your system remotely. So if you're not there at the office using your internal network, but you can still get into your system, let's say if you're out in the field doing case management or something like that, how are you allowed in and how is that protected? Additional technical security, and a big part of this is around how is the data protected in the event of, say, a server loss or there's no power, there's no network, because now that we're all electronic or getting there, that means we really need our system to treat our clients. So what is our backup and our recovery plan? Our disaster recovery, business continuity plan. That's all outlined in the security rules. Your physical security, that's your physical environment. So we have to think about locks on your doors, locks on the file cabinet. So think about your office today, your chart room, the ability to have charts laying out outside a locked room or a locked drawer. What are your rules around that? Part of HIPAA is saying specifically that PHI needs to be protected. You let everyone into your office that might have access to PHI or seeing charts on the desk or a screen with the system up? Or do you have your receptionist sign people in? Do you know who's in your office area and then when they're escorted out, kind of a thing? How's your computer monitor positioned? So a lot of us have cubicles. We don't have the luxury of having private offices anymore. Maybe you do. How is that monitor positioned? Can someone walk by the door and see your monitor and possibly see your client's PHI on that? Stay alert, stay safe. I put that on there. It's part of all of our jobs, actually. It's not just your facilities manager or your IT manager to, pay attention to this. These are items that we all have to worry about. Any questions? All right. Okay. So a little bit more about your physical security. The computer security is tied into that. Now, you can think about work, but also think about home, too, because it applies both places. These days, we have to be so aware, because there are people out there that are trying to get our identity, or get something from us. Seems like many times a day. So think about your devices. Do you have a smartphone or a tablet or a laptop that you take with you places where you can access your email, your work email, or even get into your electronic health record remotely? I mentioned the case manager out in the field kind of thing. Is your desktop computer secure and safe from somebody coming in and stealing that? How about your password? We talked about part of the security rule mentions strong passwords. Some older systems don't allow you to have a really strong password, but the point is whatever you can do to strengthen that password, you should be looking at. A lot of folks say it should be at least 8 characters, it should have capital letters, it should have numbers, it should have special characters in it, and changed often. And I know that's really hard because we're all, we all have many passwords we try to remember, but it's really important to keep that up to date and change it. Change it every 90 days or so, and also after something happens. Let's say an incident happens and someone at work clicks on a link on an email and exposes the system to a virus. Okay, your IT person's going to be involved in that and taking care of that risk. It's up to you to think about changing your password too. So just a little bit more about our computer security, our physical security. I want you to follow your agency's policies and procedures for sure. You probably already have something written up about this. If you don't or you're not aware of those, I want you to write that down as homework number 2. Go back and find out what your policies and procedures are around your computers, your software, your passwords. Make sure your monitor is not visible to others. And that includes locking your workstation when you leave. And this is probably drummed into us a lot, but we all get going fast, I know. It's important that you do that to protect that PHI. Think about your mobile devices. Number 1, are they encrypted? And if you're not sure what that means, it's a way that you can make sure your data is not accessible unless someone has a key to access that data. And that's usually you, and you know how to put your code in or to open up the data. But if I tried to pick up your mobile device, I wouldn't be able to see that. And if I did get to some data, it would look like garbage to me. I wouldn't be able to understand it. So if you're not sure about your device, if it's encrypted, another homework item is go back and find out. Talk to your IT person about that. Make sure you always know where your mobile device is. I know sometimes easier said than done, but if you lose it, you have to report that if it has access to PHI. So that's kind of the overarching here. Don't save PHI to your mobile device if at all possible. And make sure you lock it up. I know we've heard this before, put it in the trunk of the car. Don't leave it out on the back seat. I recently heard that folks now are going around trying to find rental cars and going and breaking into the trunks because they know there's going to be computers and all that in there. I mean, we can only do so much, but take that extra step. I know we're all going fast, but make sure you protect your mobile devices. We talked about passwords. Don't write them down. Don't put them under your keyboard. Remember, especially around your electronic health information or your system, someone is accessing the system using your account, it looks like you. So if you let someone use your login and password for some reason, it's an emergency, I come to you and say, please, I just have to enter this really quick. Whatever I do in there looks like you. And that could be uncomfortable sometimes. That might not be the best thing to have happen. So be aware of that. Some of you might know about email phishing, other things that hackers try to, that they use to try to get our information. So for example, you get an email, and let's say you know me, we're friends on Facebook, we're friends at the office, and you get an email from me, and I say, hey, Kim, check out this link. It's really fun. You know me, you think I'm a fun person, you check out the link, and it's really directing you to a site that's going to install something on your computer. It could just be taking your contact list for advertising. I don't know how many people have had that. Get an email from your friend, and it's really all about advertising. Or it could also be downloading some bad stuff on your computer that's going to try to take your identity, take your passwords, access things that we don't want anybody else accessing. So be aware of that. If you see a website that has a big download button, and usually they're green, don't ask me why. I think maybe we're all kind of drawn to that. Let's go, do it. You always want to make sure you're at the right site. Is the URL spelled correctly, or is there some kind of a weird thing in the address that doesn't make sense to you? Your job is to be a detective at this point because it's just happening every day, all day. This is at home as well as at work. We want to protect our information as well as our clients. And I found this little thing, stop, think, and don't click the link. Just think about it because, we're all going so fast, we're just doing it. It's just part of our normal process during the day. But I want you to think about it next time. And if something does happen, if Kim clicked on the link I sent her in my email and she thought, second thought, I shouldn't have done that, and she's at work, it's probably a really good idea to just talk to your security officer. Just say, hey, I might have blown it, but this is what happened. The sooner somebody can look at something, look at the logs, try to figure out if something malicious happened, the better. And I know it's embarrassing, but make sure you do that. Yeah.
You have to click on the link, right? Because we're so afraid that if we open the email, that we're already hacked. So you have to click on the link?
Well, usually, I don't know, I won't speak for all hackers because there could be something in there that could activate when you open it. But kind of typically, you have to take an action on it to have something trigger, But never say never. Never say, it's always one way. Any other questions?
Mm-hmm.
All right. Okay, we thought, we wanted to talk a little bit about communicating with our clients because as clinicians, that is our job, right? Communication is what you're really good at. Now we just have this additional protection we have to think about and apply. So let's say you have a client that asks you to please email them a copy of their record. They've requested a copy of their chart and they want you to email it to them. Or a client, well, let's just stick with emails first. Your email may be secure in your agency. You may have a secure email set up where you can send and receive secure emails, and that's great. You might just let your client know if they have a Yahoo account, Gmail, AOL. The minute I send it to you and you open it, you might be at risk of exposing your information. So I want you to think about that. Do you really want me to email this to you? And kind of educate them on what might happen. You might have some young folks, we're all into texting, but especially young folks. Everybody wants to communicate texting, Instagram, that kind of thing. And you might get a request that they want to be texted their appointment information or, they want you via text, that kind of thing. Remember, texting is insecure. So anything we do on our phone, unless you're in a secure container, which means that you have security and encryption set up around that, it's insecure and it can get out. So think about it. There are a lot of patient portals out there now. That's also part of meaningful use and clinical quality work that the government's working with us on. So if your system has a way, if you have a secure portal set up for your client, that's a great way to share information. And you may already be doing that today. If not, you soon will be if you have some meaningful use dollars that you're going to be receiving. So the government says we need to be able to securely communicate with our clients. They need to email us in a secure way. We need to share information. The portal is a great way to do it. You do need a release, though, and think about it, even the other scenarios I was talking about. Let's say your client really wants you to text them. You could have them sign a release that they understand the risks involved. You could talk to your privacy officer about that. Talk to your IT group. Is there any, secure texting that we have available to us? And I put a couple on here just to kind of give you an idea. There are some things out there that are available. If your agency has a large, patient population that wants to be texting, there are some things you could do to secure some of that a little bit. But bottom line is, you need a release because they need to understand the risks involved. Any questions?
Yeah. 3 issues with texting. Yeah. Question, what is that?
Oh, okay. Here, let me get my notes. I haven't been keeping up with my little notes here. Yeah, I was going to tell you about those. Okay, 3 issues with texting. Possible risk to privacy, A lack of med record documentation, so that's really something to think about too. If your client says, I want you to text me my appointment information, or text you how they're doing, all of that's outside your med record. So you might not want to do that, because that then takes it outside your documentation. And then safety issues. So let's say you start texting your client with their appointments, and then they start texting you at off hours, maybe 9, 10 o'clock at night. They're having a hard time. How are you going to deal with that? Or, 2 in the morning, they're suicidal. So you have to kind of be able to set those limits, or have some kind of a way to deal with that if you're going to open that up to folks, to protect the client as well as you. Thank you for asking that question. Okay. So we're talking about incidences or breaches. A security incident is when someone is attempting or successfully uses unauthorized PHI, gets access to a system without being authorized, or interferes with your system. And that could be anything from malware to viruses, Trojans, those kind of things we were talking about that might come into the system from our email. It also includes access control. So let's say you have a clinical person that comes upon a clerical worker who's accessing progress notes in somebody's chart. And they really have no reason to do that. They just might be looking around. They might have gotten into the wrong part of the chart. They might be curious. That would be considered a breach. Even though that person works with you, they're in the same agency as you, they know the client. If they don't have any reason to have access to that data, it would be considered a breach, or at least an incident to be investigated. Remember, minimum necessary. That's really the rule you'll find throughout the HIPAA regulation. We all need access to the data at the most minimum level that we need to do our job and to help the client. Security incident also includes losing your mobiles that might have access to PHI. It could include having your laptop stolen out of the trunk of your car. So you did everything you could, but someone broke in and stole your laptop. You were working on some of your clients' charting or some reports, and you're worried that their PHI is exposed. You really must report anything that you do yourself, that you observe, or even that you're just concerned about. Let's say after this class you go back and you start thinking about things that happen in the office. It's okay to talk about it. In fact, it's encouraged to talk about it. It's kind of the flip side of being afraid that we're going to get disciplined or written up. Your agencies should be encouraging you to talk about this, because investigating the incident is the first step. Learning from it, retraining are the next steps to keep you in that culture of compliance. Make sense? Any questions about that? Privacy rules, like we talked about, privacy is more around the client's information, the services they're receiving, their rights around their chart and the information you're collecting on them, how we're protecting their data. This is actually the definition from the regulation. And I really find this kind of nice, actually, that the government is thinking about people who are seeking care and healing. And they want us to make sure we're protecting their privacy, just like we protect them, right? And making sure that they're getting the help they need. We want information. so we don't breach their privacy. Unfortunately, there's still a stigma around mental health and alcohol and drug services, and this kind of helps some of that. Okay, what's covered in privacy? As we mentioned before, it covers paper, your oral communication, and any electronic data that you're entering in your electronic health record, in an Access database, Excel file. You might have an Excel spreadsheet on your laptop that you keep of all your clients when you see them, special notes about them, that kind of thing. That's all considered PHI. When PHI is used or disclosed, and when you need that authorization to disclose that information. Notice of privacy practices, or NPPs, included in the privacy rule, and also those other administrative requirements about when you are allowed to disclose, breach notification rules, that kind of thing. You need to know, part of this is where they can report a complaint. Who do they talk to if they're worried about some of their information? It should be somebody at your local agency level, at the state level, and then at the federal level too. Any questions? Okay. So this isn't the fun part, but now we're moving on to kind of the breaches and the sanctions and the violations. This is a quote from Leon Rodriguez. He was the director of the U.S. Department of Health and Human Services Office of Civil Rights. Remember, that's the office that's in charge of violations and penalties and auditing HIPAA. In 2012, he said, we're now moved into the area of a more assertive enforcement, which means they're focusing now on auditing and making sure we're all following the rules. I guess the thought is the rule's been around long enough, we better either be compliant or be pretty close. So we've talked about breaches a little bit. Here's the definition of a breach, and this is from the regulation itself. An impermissible use or disclosure under the privacy rule of PHI is presumed to be a breach unless the covered entity or business associate, remember now we're holding business associates just as liable as covered entities, that a breach has demonstrated and there's a low probability that the PHI has been compromised. So that's part of the whole investigation that has to occur. An incident is something that happens. You've identified maybe an impermissible use or a disclosure of PHI, and then you have to start your investigation. And that's where you're determining, is the risk low that the PHI will compromise your client's privacy, or where does it fit on the continuum? Breaches of more than 500 patient records have to be reported to the news media, and that's not just your local, metro kind of paper. That is a full publication. They make it very clear they want everyone in the community to know about it. And also, like I mentioned before, they post it on the wall of shame. Any questions about breaches, the definition? No? Okay. This is a slide of some data that I found. It was pulled in 2015. I just wanted you to kind of take a look at some of what they're finding in terms of breaches. So there was a reduction in reported data breaches. This is compared to the April of 2014. However, the breaches that were reported affected 72% more people. So that means they're larger breaches, right? And I'm sure we've heard of a bunch of them in the newspaper. This was pulled mid-2015 was already 59% higher than the year before. The 110 healthcare data breaches were reported to OCR, but those impacted a lot more patient records. Hackers stole 92 million records. That was by mid-2015. The prior year, it was 463,000. So you can see the magnitude of breaches and data exposed is just like, off the charts. I think the last bullet's kind of interesting too. Only 2 business associates reported data breaches in 2015. That's not a good thing. The government really wants us to report. So that would be a red flag to me. If I was in the Office of Civil Rights, I'd say, okay, I want to start looking at business associates. And business associates that are connected to the covered entity impose liability on the covered entity too. So just keep that in the back of your mind. If you have a contract with a business associate, you're not off the hook if they have a breach. So there are reporting requirements. Following the breach, a covered entity must provide notification of the breach. Well, they must really document, do the investigation, decide if it's reportable or not. This is assuming it is a reportable breach. The Secretary of HHS is notified, like we mentioned, certain circumstances, media. If it's your business associate, they must notify you. And in your contract with them, you should have some language called Business Associate Agreement language that tells them how many days they have to let you know that something's happened. And it should be pretty small. I wouldn't say any more than 5 days because, like we mentioned before with that security breach, you want to know as soon as possible. Knowing sooner than later helps your reaction time and your mitigation. So in the HIPAA regulation, it says that without unreasonable delay, no later than 60 days, a breach needs to be reported. Now here's the difference between HIPAA and California. California requires 15-day maximum. Okay, so they've really, and this is actually up from 5 days. It used to be 5 days. California is now giving us a little bit more time to report the breach. As I've mentioned a couple times, though, always follow your agency's policies and procedures for your incident and breach reporting. You have your privacy officer, your security compliance officer that you should be able to go to and talk to them, your supervisor, someone at your agency first to get that ball rolling. Okay, we talked about penalties. Well, here's the bad words on this. There are criminal penalties, covered entities, and individuals. That means you, who knowingly obtain or disclose PHI can face up to a $50,000 fine, and that's per year, as well as up to a year in prison. Now, this means that, and we'll go to the next slide, which has a more detailed table about this. This is if knowingly, and you're also maybe going to profit from it, you're trying to get someone's PHI for your own personal gain. So, for example, what was it, Cedars-Sinai Hospital, when Britney Spears was admitted, I think they fired 5 people who went into her chart and then wanted to sell information out. Could happen in our world if maybe you get a VIP family member, in your care. Same kind of thing, Offenses committed under false pretenses allow penalties to be increased to $100,000 and 5 years. And here's the intent to sell. So depending on, I'll go to the next slide. Depending on if it's just a simple mistake that, a staff member at your agency did, and they reported it right away. It was investigated. It was determined, yes, it was a breach. It could be $100. It could be no violation, or it could be $100, all the way up to the $50,000 maximum. All the way down to the HIPAA violation is due to willful neglect and is not corrected. So that means the same person who made the mistake, what if they keep making the same mistake? Or the mistake broadens to more patient records, kind of a thing. They're going to be imposing more of a penalty and possible jail time even. So I guess the takeaway here is understand that there are penalties involved for your agency as well as for the person that committed the breach or the incident. Important thing to remember. Any questions about HIPAA, privacy, security? Anything we've covered so far? Okay. Everybody still awake out there? Raise your hand if you're still awake. All right. Good. Okay, how are we doing on time? All right, we're good. Part of our clinical class focuses on 42 CFR. So we wanted to go over some of the 42 CFR regulations. If you're not a drug and alcohol provider, you might just listen in. You might learn something. If you are, you're probably very familiar with this, but this is kind of a high-level overview. 42 CFR was enacted really to help reduce stigma. So this is back pre-HIPAA, when folks were not accessing care because they worried about people finding out, right? And so the regulations were developed to help govern the drug and alcohol, substance use records to prevent exposure, a privacy breach kind of a thing. So the regulation, 42 CFR Part 2, some people might just call it Part 2, are the federal regulations governing the confidentiality of drug and alcohol abuse treatment and prevention records. These are around substance use, alcohol use, prescription drugs, any time that you're treating the client for these issues. It applies to any individual or any entity that's federally assisted and provides alcohol or drug abuse treatment or referral for treatment. So that can include Medicaid or Medi-Cal funding, Medicare funding, any kind of a federal support of your program. It does not really specify that, let's say, a hospital emergency room who might see a drug and alcohol client and refers them over to county substance abuse program, has to follow 42 CFR. It's pretty specific to your agency that's federally funded and you're providing your alcohol and drug treatment. The second bullet is just something that I thought was really interesting. Let's say you're a program, you might be, you think you're providing some sort of a dual diagnosis service, but you're really not drug and alcohol. If you have a doctor on site that has a DEA number, they're prescribing, narcotics or Schedule II type drugs, you might look at that because that means you might still be federally assisted and should be compliant with 42 CFR. So regulations are very specific about what we can and can't do. Any information disclosed by a program that would identify the patient as an alcohol or drug abuser is part of the 42 CFR regulations. There are some limited exceptions, just like with HIPAA, where they say there are some things that are situations where you can disclose information without an authorization. There are some exceptions to 42 CFR. We'll talk about them in a little bit. But most disclosures require a written consent. Even treatment, payment, and operations, healthcare operations. So some folks even have on their 42 CFR consent the language that services might be denied if you're not allowing us to bill for these. You know, it'd be up to your agency, but the client has to sign a written consent to allow you to bill for the services that they're receiving. That's one of those differences. It's a good example, differences between 42 CFR and HIPAA. In that case, which one would prevail? Restrictive, which would be 42 CFR, right? Good. I put the link here to the federal code just in case you're, you know, can't sleep at night and you want to read it. But it's kind of interesting that it's the code, the 42 CFR regulation. You know, it's pretty specific, and it does cover things from the patient consent, those exceptions we talked about, the court orders, how you are approved or authorized to disclose and use their information. And I'm not sure if everybody's heard, but there is a big push right now. 42 CFR is changing. They are right now collecting written feedback. So if you want to look at some of the changes and give your feedback, that link there at the bottom will take you to the place where you can submit your feedback. Seems like what I was reading, and don't quote me on this, I don't know all the specifics, a lot of the changes are around dealing in an integrated agency now and sending data to a health information exchange. You know, the government really wants us all to collaborate, coordinate care across primary care, behavioral health, substance abuse, you know, specialty care, emergency rooms, the whole effort to reduce the cost of healthcare. So if I've had a lab test done at my primary care office and my psychiatrist wonders about my lab results, the goal is that the psychiatrist should be allowed to go in and see what my lab results are that were done at another location. So I think what they're trying to do is look at the 42 CFR regs and make it more amenable, is that the word? Mm-hmm. To share the data across the different specialties or agencies. Any changes about that? I'm sorry. Questions about that? Yeah.
Is there a Part 2 specific in California?
No, it's a good question. So 42 CFR pertains in California too.
And is it only for adults, or how does it affect adolescents in treatment?
Well, Drug Medi-Cal has a different rule about that in terms of consent kind of a thing. I don't know the specifics, but you still need a consent to release information, even for a minor. Which is a good segue, written consent. So the consents are so important in 42 CFR. I wanted to talk about it a little bit. The law does state that in some cases you can accept a verbal consent, but you have to follow up immediately in writing. They must give the patients a written summary of the federal law and what steps they're taking to protect the confidentiality of their records, and a description of the circumstances when the patient's information may be disclosed without their consent. So I know there's a lot on this slide, but I wanted you to get a sense of what should be included in one of those written consents. This is right from the regulation. Your county, your agency may have decided to add some additional information or language on the consent, but they must be obtained in writing. You can have a single consent that covers multiple disclosures or authorizations for disclosures, but you have to be very specific for each of those disclosures. And the column on the right there, those are all the items that must be on your consent form. So the name, the agency making the disclosure, agency name of the person or agency to which the disclosure is made, the nature and amount of information to be disclosed, and it has to really be the minimum necessary. That's very specific. It could be check boxes. It could be a text box that you write in, but it has to be very specific. Why you want to disclose the information, what's the purpose, the effective and the expiration date. Maximum is a year, so you have to get these consents renewed every year or as soon as they have expired to continue to disclose their information. There is a language that you can include explaining the consent process. You may include that language I talked about where you can deny services if they're not allowing you to bill or work out some kind of a payment arrangement. And everyone has to sign. The client has to sign, their authorized representative if they're not in charge of their own legal matters, and description of authority to sign on the client's behalf. So if you have someone else signing, they have to document their legal right to sign. Make sense? Any questions about the written consent?
You're required to provide an MPP every time you get a written consent.
No. MPP you only have to do once a year or on admission, you know. But the 42 CFR consents need to have an expiration date, and a year is the maximum. You have to renew those. Okay, we talked a little bit about exceptions. So there are some exceptions to disclosing some information on your substance use clients without a consent. But I have there in bold, always work with your privacy officer. Don't take it on yourself to feel like because it's here in the slide, you can share information without a written consent. It's very specific. You can talk amongst yourselves around your program, your care planning, without a consent. There's another thing, and I think they're even thinking about getting rid of these in the new update to 42 CFR. An organization called a Qualified Service Organization, or QSO. Sounds like it's kind of similar to a business associate. And the rule states you can talk to them without a consent or written consent. Medical emergencies. So let's say you have to call the ambulance because your client, you know, passed out, having some kind of a medical emergency where they need attention. You can give some information. If you have folks starting a fight or hurting your staff or hurting other clients and you have to call the police, you can share information, minimum necessary, but, you know, in the event of an emergency or to respond to that crime. Some research activities, suspected child abuse or neglect, response to a valid court order. You can also let the cause of one of your clients' death be known without them having signed a consent about that. I don't mean to laugh, I'm sorry. But like I said, always work with your privacy officer because it's such a specific rule and regulation. You don't want to do anything that might be a possible breach. Oh, sure.
Our release for drug and alcohol states the release expires 90 days after discharge. Is that allowable? As I thought I heard you say they were only good for 1 year.
Well, it's up to your county council. If that's your release, that's fine. I was saying that if the client's still in treatment, you should revisit those releases every year. They all have to have an expiration date on them. That's probably to cover your billing period and make sure everything in the chart is all finalized before you close the chart. So that's okay. Is that it? Okay. So just like compared HIPAA to the California rule, the CMIA. I wanted to compare HIPAA to 42 CFR. Same idea. There's two regulations. These are both at the federal level, by the way, but still we have to go by that same rule. The more stringent rule applies. I gave you a link there to a blog that I thought was really interesting. They took 42 CFR and compared it to HIPAA. It's not every point in the regulation, but it kind of gives you an idea of which one might be more strict. And let's see if I put that in there. I didn't. Okay. So when you go through, I want you to all to look at this blog because it's a nice table. They go one by one. What is really pretty apparent is 42 CFR comes out to be the most stringent rule. And so if you're a drug and alcohol program let's say you're following HIPAA because that's federal level, you're also following 42 CFR in your drug and alcohol or substance use program, that's going to be the one that you're probably going to follow most often. There are some different HIPAA language that you want to add to some of your drug and alcohol forms, but pretty much my research is showing that 42 CFR is the most stringent. That's kind of interesting. So I want you to go out and look at that blog. Now, you may have heard of SAMHSA. They're Substance Abuse and Mental Health Services Administration. They're at the federal level. They're a great group. They do a lot of work on mental health, getting the parity laws set up. They're a great group. Alcohol and drug services, they're involved in everything. And they're one of the groups that are really actively pushing the 42 CFR changes. So you might look at their website there. I gave you the link. And look to see what they're recommending for the 42 CFR changes. Like I was saying earlier, it's really a lot of the changes are around electronic health records and health information exchanges, making it a little easier to share that information. And if you look at some of the comments out there, the public comments, a lot of folks don't want that. A lot of folks are still very concerned about stigma and don't want drug and alcohol records exposed. So it'll be really interesting to see how this all plays out. I believe that the public comments period is open through the end of April. I want to say April 26th. So check it out and get your comments in if you're still interested. Okay, any questions? All righty. So now we're going to kind of go back to HIPAA. Even though 42 CFR requires policies and procedures too, we have a bunch of those, as I'm sure we're all aware. As I mentioned, the HIPAA regulation is 45 CFR. It's very specific about policies and procedures that your agency must have as part of your compliance program. They want you to have an interconnected set of policies, procedures, different plans, and those security roles we talked about assigned. So in the end, they want it to be an agency-wide program where everyone is involved, people understand who's responsible and what they are responsible for. And it has to be auditable, meaning it's a standard process. If they came in today to audit you, you would be able to present to them your policies, your procedures, those plans, and the kind of plans we're talking about are your disaster recovery plan, an incident response plan, your physical security plan. How are you guaranteeing that your agency is able to handle privacy and security under the HIPAA regulations? Sure.
Are expiration dates needed during a crisis or continuity of care on a release of information form?
During a crisis. Well, I guess we'd have to define crisis. If it's one of those, the fight's going on or staff are being harmed and you have to call the police, you don't need a written consent to release information? Is that what the kind of crisis we're talking about? I would say, good rule of thumb is when you start serving your client in the alcohol and drug program, have them sign a release for TPO minimally. Maybe that was that one we were looking at, the good 90 days after discharge kind of a thing.
He says at the ER, 5150 evaluation.
No, I can get back to you on that. I'll research that specifically, but I would think when you're doing a 5150 on a client, they wouldn't need to sign a consent. And are you referring to a drug and alcohol program, or you're putting them probably in the hospital, right? Yeah. I would say no, but I'll take that as I'm going to get all the questions from Show like we did before, and we'll put the answers out, questions and answers out on the website. I'll look at that one specifically to see if there's any kind of nuance that I'm not thinking of that might address that. Good. Okay, so just a little bit more about policies. Just another homework. I'm sure you all know where to find your policies and procedures, but what I want you to do is I want you to write down, do you know where your policies are that are sort of more HIPAA related? So what we were talking about today. Here's a couple examples. Workforce training, incident response, sanctions and violations. Where's your policy about staff incidents and what happens to staff if they continue to break the rules? Access control, acceptable use. Do you have a policy and a procedure about how you are allowed to use software or the internet or Facebook or social media in general? I want you to go back and ask your privacy officer or your security compliance officer, what policies do we have that pertain to HIPAA? Because you are responsible to know those. Hopefully you can see my cartoon. I thought we just needed to laugh. Kim, you might not be able to see it from back there, but this is how we kind of start feeling, right? It's like we can't do anything. But I really don't think the rules are trying to tie us up like this or put bags on our clients' heads. But we want to be aware. Procedures are the how to your policies, right? So how do you go about reporting a possible breach? How do you go about asking for additional access to your electronic health record? Or, how do you, how are the staff, going back to those examples we talked about, how are the staff disciplined? Now, a lot of this might be government agencies where you have your disciplinary response all lined out. Well, how does HIPAA fall into that, right? Are you allowed to discipline your staff if they continue to breach? Not just a simple mistake, I blew it, I faxed something to the wrong number, I transposed the number, or repeated, incidents that they're not seeming to learn from their mistakes. What do you do? How do you handle if your client requests to see their chart or to get a copy of it? Do you know where that procedure is? It's really your responsibility as a clinician to know how you fit into all these procedures and know what you can do, how you do those, and who to talk to if you're not sure. One of the things we talked about, one of the plans was disaster recovery, business continuity plan. You might have one of these as part of your agency, if you're a county, working with the county as a whole on their plan. How it might affect us as clinicians is, let's say the system is down, there's been an earthquake, and the server room was compromised. So we can't access our electronic health record. What are we going to do to continue providing services to our clients? Probably the services would increase. You probably have a lot more people coming in. That might be covered in your triage plan or how you're going to respond to the emergency. What are you going to do in terms of understanding what medications your clients are on, how to access their history? Think a little bit about that, because it's really important. You might have a plan to shelter in place or whatever your disaster recovery plan talked about today, but take it that next step. How am I going to treat my clients if I don't have my electronic health record? Downtime procedures are really important. If you don't have those, talk to your IT person or the person that helps you manage your record. What are our downtime procedures? When are they activated? How many hours can we be down before we have to do something in the meantime? Most people resort to paper. So you have your forms all lined up so people know where those forms are. Do you have a way to back up your medication orders so you would know what medications I might be on in the event of an emergency? It's all around client safety, providing the services we need to continue to provide without our systems. Because now, I don't know, I can't really see you guys, I can see Kim, but most people are in electronic systems today, you know. Are you, Kim? Do you guys have any HR? Yeah, she's shaking her head yes. I'm assuming most people are shaking their head yes. We're all trying to get to that point. We might not be totally electronic yet. You know, we might still have a paper chart, but that's the goal, right? So it's real important to think about this as you're considering your disaster response. Any questions?
No.
Nope. Okay, so what you're doing today is part of your HIPAA training. That's awesome that you're here. HIPAA regulations state that staff need to be trained on HIPAA when they're hired annually, and then you should have subsequent trainings throughout the year or reminders. It doesn't have to be a sit-down training. It could be a screensaver that comes up with a HIPAA tip for the day. It can be a poster. It can be a newsletter. It could be mentioning it in a staff meeting and keeping that on your agenda. The whole idea is to create this culture of compliance. If you Google that, you'll find that, you know, the feds are really wanting us to embrace HIPAA, not to, well, sometimes I kind of wonder if it's to get more money out of us in terms of violations, but no, it's really to protect our clients' information. Clients need to trust us as care providers that we're going to be servicing them and taking care of them, and also trust that we're going to protect their data, just as we do them. You know, think about how you would feel if, you know, your doctor called you up and said, you know, I'm really sorry, but I lost your record and it had your lab results that shows that you have HIV or something. You know, I mean, it's discouraging. It's something we all have to think about. So I put that in there. These are not meant to torture you, although you might feel tortured right now, but it's really not. Okay, we're almost done. We covered a lot today, I know, and we covered it in a, you know, pretty short amount of time. We wanted to kind of run through this as an overview. Didn't want to take up too much of your time, but give you information that we felt you needed to understand about HIPAA, high-tech, PHI, that whole idea of the most strict rules. So strictest, California versus HIPAA, 42 CFR versus HIPAA, even some local rules that you might have in place. And I really wanted to stress the importance, kind of some of that security training. That is something that HIPAA asks that the security compliance officers train the staff on, well, a little bit of what we talked about today, your computer safety, your physical safety, how you can protect yourself, organization, from, you know, allowing hackers to come in and do some damage. We talked about what you can do to protect the PHI breaches, how those are defined, the penalties associated with those, 42 CFR, HIPAA, which is 45 CFR, agency, your policies and procedures. We talked about training. Any questions? Yeah, Kim.
Do you have a link or a resource that has something listed on there about best practices, things to do on a daily basis, things to watch out for, or tips?
In terms of the security, the computer security?
Just about the whole thing, actually, just some tips, things to know. It's kind of like an easy bulleted thing, because this was really useful to find out, the laws, the regulations, the limitations, and what's expected. But as a clinician on a daily basis, kind of like a go-to thing. Hey, remember, you can't do this, or remember, these are the best practices. Something easy, layman's term, maybe.
You know what? I'll pull something together. I'll look around and pull something together. So like a little tips and tricks sheet for clinicians around HIPAA, 42 CFR, computer security, that kind of thing. Okay, that's a great idea. Yeah. Can you? Oh, that's fine. Oh, that's fine. In fact, we're almost done. So what we wanted to do, the class was scheduled till 3:30. We wanted to give you all time to take your exam, because there's an exam to take at the end. Now, I know you don't have your laptop, Kim, so it's okay. And I know some folks might be in a room together watching this. That's fine. Everyone needs to log in and take their exam. One of your references is the instructions. So if you go to xdalehealth.org/CIBHS, you're going to see the form where you can log in, register to take the exam. You'll also see the webinar there too. You're very welcome to watch the webinar. It's the same slides. It's me talking, so I'm sure I'm saying different things today, but you don't have to. You can go right to your exam. And on the instructions, there's a discount code, and you're going to use that when you register on that site.
Let me just say the exam instructions are uploaded to your handout tab, so you should be able to access them right now from your webinar dashboard.
Okay. And we can keep the webinar going if people want to log in now. If you have any problems registering for the class or navigating, I can be here to help you with that. It is a little tricky in terms of navigating. So does everybody know what a breadcrumb is? At the top, you're going to see a link that will take you back to another form or another slide on the. I want you to navigate back to that if you need to. At the end of your exam, you'll go back there and refresh your screen, and that's when you'll see your little button to print out your certificate. So does that make sense? I don't know. Do we want to give people time to just try that out now? Yeah. Okay. Before we do that, too, the last bullet I thought was really important, or maybe second to the last two. Feel really proud. You completed this. I know it's hard taking time out of your day to do training. And share what you've learned today, Share some awareness you had today during class, because we want your agency to have that culture of compliance. And that means it's an awareness that everybody has, as part of their daily job, their daily life. So, yeah.
Can you repeat the breadcrumb explanation?
Sure. So when you go onto the site and you get logged in or registered, it's going to take you to a form that will have some links at the top of the form. They're in the top left. And as you go through, let's say you take your exam, those breadcrumbs will still be there, and that's how you can get back to your previous page. It's a way to navigate a website. They call them breadcrumbs. There's also in the upper right menu bar or toolbar, there's a link for a dashboard. If you're ever lost or ever in doubt, use that dashboard too, because that'll take you back to the beginning, and then you can click on the exam and get yourself reoriented.
And someone says, I am not finding the discount code. I just looked at it, and it's at the top of the second page.
Yeah, it's at the top of the instructions. It's CIBHS _ HIPAA, HIPAA 0.
And if you're looking at the exam, at the instructions, it's at the top of the second page. Yeah.
Okay, we have it. I see, got it. If you don't have time to do it today, I'd say do your exam as soon as you can, just because it's fresh in your mind. We'll probably take it down in a couple weeks, but then we're going to talk about how to make the other classes available and kind of how that might work. Because we did a HIPAA overview for executives, and we did a technical training a couple months ago, last month. This will be the third class.
Looking for I can't find the exam.
Okay, so they have to go into that HIPAA clinical course. I wonder if I can do it here.
Yeah, show them what to do. And did you say, no, CIBHS
_ Everybody know what that is? Yeah.
HIPAA
03. Okay, so if everybody can look at the screen. So I've gone into xpiohealth.org /CIBHS, and this is the form you should see. Even though it says purchase, I'm going to give you that coupon code so you don't have to purchase it. So hit that little blue button there to purchase. And then check out, because that's all you want to do. And you're going to, I missed my coupon code. Here's have a discount code right here. You're going to click to enter that here. And it's CIBHS _ IPAA 03.
Does it have to be all caps?
I'm not sure. That was the instructions that I have. So enter it all caps. I'm not sure if it's case sensitive though. And then what you're going to do. Yes. Is there a question? No. Okay. I thought you were breathing to ask me something. Enter your email address, your first name, and your last name, and then you'll be creating your account, username, and your password. Ask you to enter your password again, and then you'll be in. Let's see, I already have an account. And once you register, let's see if I can get down here. Let me go back. Let me see if I can show you my breadcrumbs here at the top. No, they're not here right now. So Kim, do you think you have enough? Do you have the instructions so you can go home and do that? Okay,
Yeah.
good.
When will you notify us about the, and how?
It'll probably be on the website,
Okay.
and look for it in a couple weeks. Do people get an email or something when the website's been updated, or do they just have to look out there?
We can send an email to everyone who attended and let them know where, give them the link and let them know where to find it.
Okay. Thank you. Thanks for coming in.
Thanks for having me.
Yeah, I'm glad you were here.
Are we ready to end?
Let me just see. Out. People dropping off.
Thank you.
Thank you.
Okay.
Bye. I'm going to do this to see if I can show them. Yeah, they already have an email. I already have an account.
It says it is.
Yay! Okay, good. Well, here's my login. Do this last time, and I confuse people more messing around with it. Is anybody still on?
Yep.
20,
All right, is that you, Randy?
24.
Okay, good. Okay. There we go. Okay, good. So that's the form people should see. They click on the clinical, and they don't have to do the class, but they do the exam. Once the exam's done, you get the green check, refresh, which is that little arrow at the top, and then you should see your print your certificate button. There we go. Leave that there. Any other feedback, any?
No.
Okay. Good. We finished in enough time. I wanted people to get a chance to do things.
If any of you have questions about accessing the exam or the certificate, type them in the question box. We can stay stay on for a few more minutes, but if we don't hear from anyone, we'll assume everyone's doing fine and doesn't have any questions.
These are the breadcrumbs I was talking about. Here.
Doesn't look like anyone is
Okay.
needing help.
Well, thank you, everybody.
Thanks, everyone.
Have a hip healing.
Thank you.
Bye.
Is that you?
Randy's still on?